Good morning, everybody, and welcome to the TIRO Multidisciplinary Seminars. We have an outstanding program this morning. It's a thyroid tumor board, which we offer 8 times a year. And we have an outstanding panel to present 3 cases, which I think will be extremely informative and challenging. I do want to put in a quick note of advertising here, the Voices of Wisdom podcast, which we launched last month. And we'll be sending out one each month through the remainder of this year. And we've got the 2025 roster of these podcasts already scheduled and will be in production soon. The next podcast is due out next week and will be a discussion by A.L. Robenstock to talk about active surveillance. And so without further ado, if we could just have everybody on the panel present their title and what connection they have here. Mike, do you want to start things off?
Absolutely. Hi, I'm Mike Tuttle. I'm one of the endocrinologists at Memorial Sloan Kettering Cancer Center. I had the pleasure to try to moderate these panel discussions, although when surgeons present, there's always a balance about how much I get to moderate, so we'll see what happens. Thanks, Mark.
Yeah, Lisa?
Yeah, good morning, everyone. I'm Lisa Orloff. I'm a head and neck surgeon coming from Stanford, California, bright and early.
Dr. Brito?
Good morning, everyone. I'm JP Brito, endocrinologist at Mayo Clinic here in Rochester, Minnesota.
Rodney?
Oh, you're on mute, Ronnie. There you go.
Hi, I'm Ronald Ghossein. I'm a head and neck pathologist at Memorial Sloan Kettering Cancer Center in New York.
Okay. Dr. Azita?
Azita Khorsandi. Good morning, everyone. Radiologist at Mount Sinai.
And Dr. Worden?
Frank Worden, a medical oncologist at the Rogel Cancer Center at the University of Michigan.
Terrific. Monica?
I'm a nuclear medicine physician from Prince of Wales and Sydney Children's Hospital in Sydney, Australia.
Terrific. And my colleague at Mount Sinai, Dr. Raymond Chai, who, Ray, if you just want to give a quick intro, and then we're going to turn over the first case to you.
Yeah, hi, everyone. Good morning. Raymond Chai. I'm a head and neck surgeon here at Mount Sinai. Okay, let's get started with this first case. Again, thanks for the invitation to present today. So this is a 68-year-old male presented in February to one of my laryngology colleagues with gradually progressive hoarseness for 10 years. He actually had seen an ENT a year prior, which is thought to be just edema of the larynx from smoking, but there is no neck mass. There's nothing that he feels. He has no pain. There's no issues with swallowing. Breathing is fine. No other symptoms. Heavy smoker. He's somebody who does have sleep apnea and is on CPAP and does have a BMI of 35. He is obese. Next slide. So this is a picture of his video of his stroboscopy that was done by the laryngology team, which clearly there's bilateral true vocal fold motion right here. There's some edema of that right vocal fold. And posteriorly, if you can see, the vocal process in the back has some thickening, which is actually thought to be an inflammatory granuloma. Next slide. So he was taken back to the operating room by the laryngology team, in which this unfortunately was diagnosed as a right vocal fold squamous cell carcinoma that extended from the vocal process posteriorly all the way to the anterior commissure and involving something called the saccule, which is right above the vocal fold. That vocal process posteriorly had necrosis, but a biopsy here was negative, and that's important because that can impact vocal fold function. And the left vocal fold had some edema, but was not biopsied in order to prevent worsening hoarseness with a glottic web. Next slide. And so this is a CT neck was then performed. Again, it's not a great picture of the thyroid. This is probably the best slide that we could get with this. But if we want to comment on this, Azita?
Azita, I think you may be muted.
Yep.
Okay. So right lobe shows a focus of lucency that sort of abuts the tracheoesophageal groove, and the posterior wall, tracheal wall, I don't like it when there is an interface of a nodule with the trachea or adjacent structures. On ultrasound, on CT, that's always a red flag for me to raise extrathyroidal extension whenever I see that. And then there are bilateral neck nodes on the left posterior to the left jugular vein, so that would make it left lateral compartment, level 4, and on the right, sort of lateral to the right common carotid artery, so that would be another level 4 lateral compartment lymph node, enlarged by side.
Azita, when you use the term interface, for the ones of us that don't look ton of these CT scans, what do you mean by that interface between the trachea? Now, sometimes they're touching it. What do you mean by that?
Touching it. So if you look at the contralateral tracheoesophageal groove on that first image that we have the lucency, there's fat between the esophagus and the left lobe of the thyroid gland. If you look at on the abnormal right side, you see the nodule is lucent and that it abuts the tracheal wall. That's all I can say. It's very rare to see endotracheal extension. This is where it's really difficult when the surgeons ask, well, is there tracheal invasion? Is there perichondrial invasion? I don't know. But when I see this, I'm always suspicious of extrathyroidal extension.
Gotcha. Ray?
Okay, next slide, please. Okay, so he then comes back to the office again. This is April 4th, in which he has no new symptoms. This is after the biopsy. So the voice is exactly the same, nothing with swallowing, nothing with breathing, but with clear new right vocal fold immobility. It's clearly paralyzed on that right side right now. And so that's the question. Is this from progressive larynx cancer? Is it from the thyroid, something else? And so this prompts additional imaging. There's a CT chest to look at the entire course of the recurrent laryngeal nerve. That's negative. And that's when biopsies were done of the thyroid, so the right thyroid, as well as a right level 3 lymph node. I picked this slide of the ultrasound. It's probably the best cut that I could get. It's not super clear, but if you want to comment on this.
Yes. So there are many adverse features with this thyroid ultrasound. If you look at the most posterior border, again, there is no interface with the adjacent structure. So that is a big red flag for extrathyroidal extension. The lesion is hypoechoic, which is another poor feature, which is one of the poorest features when you look at the TIRAD. And if you look at the borders, are all irregular. So those are all poor prognostic features for a thyroid nodule.
Okay, so this is the FNA here of the right level 3 lymph node, and this is followed by the FNA of the thyroid, if we want to comment on that.
Yeah, so basically clearly here you can see malignant cells, pleomorphic. Can you go to the next one? Here again, there is no question, especially in the right upper panel, definite nuclear pleomorphism. So this is what we would call positive for malignant cells. And let's go to the next one. So here is the immunoprofile. So you can see that the cells are positive for P40, which is squamous markers, as well as P63. Interestingly, they are negative for PAX8 and TTF1. And this negativity really rules out a differentiated thyroid carcinoma, for example. So now we're not the, so this it has an immunoprofile of a squamous carcinoma, quote unquote.
Right, and that's, the reports show right level 3 lymph node, rare atypical cells, flow negative, suspicious for malignancy. And for the right thyroid, the report had poorly differentiated carcinoma with necrosis consistent with squamous cell carcinoma, and TTF1 negative, thyroglobulin washouts negative. So this is
Dr. Urken, help me here. I don't know anything about squamous cells, and it was cool to see things move. I can barely understand. Is Ray going to try to sell me that you've got this squamous cell up in the neck in the thyroid, or spreading to the thyroid? What's going on here, Mark?
Well, I think that's the 99% of the time, if we see a malignancy in the thyroid associated with a pathology in the larynx, which we used to see all the time in the old days of of laryngeal cancer, when folks presented late, and so most of the time you can see metastatic disease from the larynx to the thyroid, and so that's got to be what was being thought of at this point here.
Azita, there was a nice question that came up that followed up that said, if there's, would an MRI help you when you're trying to figure out extra thyroid extension?
No, we generally don't do that. The issue with MR is at the cervicothoracic junction, there is so much artifact. No matter how much I try, it just doesn't help. My best imaging tool is my CT scanner. Especially if you look at it, this patient has big shoulders. On MR, I would just fail. It would just be an extra study.
Gotcha. And Ray, help me think through this now. You were living this real time. What were you kind of thinking when we got to this point here?
Yeah, I mean, all this is actually before the patient saw me.
Ah.
But again, it's a very just unclear picture right now. Like, what's going on here? Is this the larynx cancer? Is this going to be from the thyroid? Again, we're getting more imaging, kind of getting more data points right now, but that's
Okay.
the issue, is that what is this actually from?
Okay, let's keep going.
All right, so this is the April 18 PET right here too. There's no distant disease, but if we want to comment on what we see.
So the right lobe of the thyroid gland is hypermetabolic. I'm not sure if it's just a nodule that is blossoming on a metabolic activity or if it's the entirety of the right lobe. I can't tell. And we see that, I think that's the lymph node behind it. And again, it's both of them. It makes me suspect for recurrent laryngeal nerve invasion. And if there is right vocal cord paralysis from this right-sided lesion, which we don't know what it is, the other panels, I think one of them shows a right level 3 lymph node. And I generally don't like evaluating larynx with PET because right now, if you look at the image on top, it's swollen, it's post-op. It's probably less than 6 weeks since they went into OR and operated. Is it that the right side is paralyzed and the left side is picking up FDG because of the paralysis? I don't want to make any comment, the truth, about the larynx.
All right, Lisa Orloff, Dr. Orloff, what are you thinking here? What's going on? What are you sort of thinking about? Because obviously we're going to want you to do some sort of surgery here. So what are you kind of thinking about here? Oh, you're muted, Lisa. Unmute there. There we go.
Unmute.
There you
To
go.
be
Yep.
honest, I am really impressed with the workup of this patient because I think, in looking at these images, even starting out with the detection, the follow-up and detection of vocal cord paralysis after prior intact mobility, it was a really astute sort of continuum of care for this patient. And the original images were not that impressive. And I think it sort of emphasizes that size isn't always the most important issue here. I think that lesion in the thyroid and both on the CT and the ultrasound could have easily just been blown over and written off as very, very non-relevant or non-worrisome. So I'm very impressed with the sort of the follow-up and care of this patient. But I'm wondering the same thing: is this cancer that started in the larynx and went into the thyroid, or cancer that went into the thyroid and that started in the thyroid, went into the larynx? And I think it definitely didn't get tissue on the laryngoscopy. So I would want to get tissue, for also BRAF. I didn't see BRAF testing on the initial markers. I don't know if that was done.
Why think out loud for me, Lisa? Why BRAF out of the millions of panels that we could do? What do you think with BRAF?
Well, this is turning into an ugly looking cancer that's behaving very aggressively and apparently growing quickly, and making me wonder about anaplastic thyroid cancer. And the one sort of finding that would make this seem more easily treatable or more perhaps give you more time would be if there's a BRAF mutation that would be targetable and could be amenable to neoadjuvant therapy.
Frank, from your lens as a medical oncologist, this is going to be thyroid because we're at a thyroid tumor board. I get that, but is there anything else we should be thinking about while we're trying to work through this, Frank?
It's interesting as a head and neck medical oncologist too, when this whole thing about organ preservation. If I look at this, there's no distant met. So it goes through my mind. And obviously, we defer to the surgeons, first. We are I'm probably the most adjunct person here. But if there, this person, if they're going to undergo surgery, I'm assuming you're going to take the voice box. And so the question would be, you know, organ preservation. So chemotherapy and radiation would work for both squamous cell as well as thyroid cancer. So that's something that has come to my mind. But what I'd want to know from the surgeon is, because I heard about the vocal cord paralysis, you know, swallowing intact, do we think there is a chance for recovery? I mean, there's no reason to do, you know, chemoradiation if we think we're not going to, you know, have good, you know, vocal cord activity, you know, following, you know, treatment. We just go straight to surgery.
Before we move on, let's one more question. Monica, the Lisa raised the question about maybe being anaplastic, maybe being poorly differentiated. Is this, when you look at this PET scan, does this ring bells for you for anaplastic? Or, I mean, it's kind of cheating, but when you look at it, what do you think about it?
Well, it is FDG avid, so that would mean that it's more aggressive than a standard thyroid cancer.
Yeah. Okay. All right, Ray.
Okay, so one more data point right here. This is actually but get the next slide. So this is actually a biopsy of the left lymph node, if we want to comment on that.
Yeah, I think it shows, again, also, in my opinion, the same tumor with this glioma. I think it's positive. I would call it positive, yeah.
The same tumors in the thyroid, Ronnie? Is that what you mean?
Yeah.
Is this thyroid cancer?
I can't tell on this FNA. I will be needing stains, and obviously the ideal if I can get the thyroid.
Gotcha. Perfect. All right, Ray. So Ray, we're still kind of stuck here, right? We know it's a cancer. Yeah. Yep. Go ahead.
So, you know, the report here also just showed markedly atypical cells, background of necrosis. In fact, I spoke to the cytopathology and thought this looked like Hodgkin lymphoma. So a lot of things going on right here, but this is a pretty spirited tumor board discussion about what's going on here, right? Is this something which is a metastasis from the larynx? Is it a separate process? How do you sequence? How do you stage? You know, do you do surgery up front for the thyroid, then treat the larynx? Do you radiate everything? Do you treat the larynx alone, then you do a stage treatment of the thyroid? Or, you know, again, I think that great comment about BRAF. We don't have that at this point, but what about a neoadjuvant approach? So, you know, these are all kind of questions thinking about right now. But, you know, after discussion here, because this is thought to be a very poor player in the thyroid, we ended up doing the thyroid surgery first. And if you want to go to the next slide. So we did a total thyroidectomy, central neck dissection, bilateral neck dissection, and it became pretty obvious early on that the nerve was invaded by thyroid cancer. So it's gross invasion at the laryngeal entry point. There was clear, obvious extrathyroidal extension to the tracheal perichondrium, the cricothyroid muscle, the inferior constrictor muscle, but we were actually able to clean this out pretty nicely. We did a tracheal shave, took the musculature down to pharyngeal mucosa. So certainly a gross complete resection right here. Patients in the hospital for 2 days, actually ended up doing fairly well and went home.
And Ray, this felt like a poorly differentiated thyroid cancer surgery, a lymphoma surgery, an anaplastic. I mean, your gut feeling while you were doing it was what?
Yeah, poorly differentiated or a high-grade PTC. It just didn't seem like anaplastic to me because actually everything was pretty clean just up until that point at the laryngeal entry point. We were able to get everything out pretty nicely. So it did not seem like anaplastic to me at the time.
So,
Okay.
yeah. So Ray, I guess one of the tip-offs here was just the rate of change of the physical exam findings here, and the laryngoscopy probably was weighing on your mind.
Yeah, absolutely. But that's also the question too, is that the vocal process, and that's why I brought that up in the beginning. You have necrosis there from the beginning. I know on imaging, it's pretty hard to tell if you have posterior extralaryngeal extension there that may have caused this. And again, the thing about the patient also is that he had no new symptoms at all between this interval when he had motion and when he did not have motion. But you're right. You know, I think that was weighing heavily about how this was, you know, a thyroid first surgery before treating the larynx.
Or some other tumor, which is why you chase the entire length of the RLN, right? This could have been something else along the path. Okay. All right. So Ronnie, what are we looking at here?
Let's see the slides. Yeah. So this is obviously the thyroidectomy specimen. On the left, you have the normal thyroid. On the right, you have clearly a tumor, and at this low power, there seems to be necrosis and fibrosis. Can we go to the next one? On this power, you first realize that this tumor is not making any papillae, any follicles. Even at this low power, you can see there are no solidness, so it looks like sheets of thyroid cells. So this is obviously worrisome. Can we go to on a higher power? So here you can see it's not the greatest high power, but you can see clearly in the right upper corner the tumor necrosis. Now, tumor necrosis is a big deal in thyroid tumors because immediately it puts the tumor out in the either high-grade differentiated non-anaplastic or fully differentiated category, or obviously in an anaplastic category. So more and more now, looking at the cytology here, where there is pleomorphism, no follicles, no papillae, and a lot of mitosis looks like. So clearly now I am worried about anaplastic thyroid carcinoma. However, the diagnosis of anaplastic carcinoma always, in my opinion, needs immunostaining. It's really crucial. It will be interesting if that was done or not. Let's see next one. So here I see areas of follicular growth. To be honest with you, this could be two things. Could be actually a better differentiated component here from papillary carcinoma. I'm not so sure. I have to see the whole thing. But if it is, when the tumor are very aggressive, especially anaplastic, sometimes they can create, they can induce reactive nuclear atypia in the follicles. So, however, of course, if it is a better differentiated component, it will make my job much easier in diagnosing anaplastic. Here, actually, the BRAF V600E immunostain, that is wonderful because it's against the mutated protein, can make a big difference because this driver is conserved in the anaplastic and the better differentiated component. Here, I will be able to tell if this anaplastic is coming from a better differentiated carcinoma. But the other differential that initially was brought because of the laryngeal biopsy was squamous cell carcinoma. Now, by H&E, based on experience, it doesn't look like a squamous cell carcinoma of the upper aerodigestive tract. But here, again, stains can help a lot. PAX8 can be positive focally in anaplasty, but is negative in, for example, upper aerodigestive tract squamous cell carcinoma. So really here, there's a large need for immunostain.
Yeah, give him the stains, Ray.
So
Yep, go ahead.
Yeah, the stains show that it is a carcinoma, so not bad. It is actually has squamous differentiation because it has P40. Now, unfortunately, it's negative for PAX8, so I cannot use a positive PAX8 to rule out upper aerodigestive tract squamous cell carcinoma. It's, as expected, negative for TTF1 thyroglobulin. So definitely now we are out of the differentiated thyroid carcinoma. This is definitely, if it is thyroid cancer, this is an anaplastic thyroid carcinoma. Now, of course, if you put everything together, especially the epicenter, the fact that the epicenter of the tumor seems to be in the thyroid, this is, in my opinion, compatible with anaplastic thyroid carcinoma. Of course, the P53 that is seems to be of the mutant pattern overexpressed, and the Ki67 is very high. Point toward that diagnosis.
Hey, Ronnie, help me.
But BRAF will make a big difference because also it's very unusual in squamous cell carcinoma. Yeah.
Ronnie, help me. I'm used to the anaplastics not having TTF1 and not having thyroglobulin. They lose PAX8 all the time or most of the time?
No, so PAX8, depending on the antibody you use, if you use a monoclonal antibody, which is the most specific, PAX8 is present in 50% of anaplastic. So yeah, you have anaplastic that are negative for all markers, and we still I can make the diagnosis if I put everything together. That's why it's very important that I talk to you, to the clinician. If it is thyroid-based, a rapidly progressive tumor in a older individual, then it's fine to say consistent with or compatible with anaplastic. But really, the BRAF here would have helped a lot. Yeah.
Yeah, and Ray, they obviously had comparisons. You had the primary larynx. So tell us about that.
Yep. So, I mean, this was actually reviewed directly with that March larynx biopsy, and it was felt morphologically different things. So, we looked at, is it direct extension or metastasis? That's excluded. We also looked for a more rare spindle cell variant of squamous cell carcinoma, and that was also excluded. Can we go back actually a couple of slides? I just want to go to the pathology report. Just keep going back. Yep, back. Yep. So this is the pathology report right here. So it's a 2.3 centimeter anaplastic thyroid carcinoma with necrosis. The margins are microscopically positive, but again, there's no gross residual disease here. It's just impossible to get widely around this without an upfront laryngectomy. 2 nodes in the central compartment. The one with E&E probably is the one that was FDG avid on the PET. And then 2 positive lateral compartment nodes, one with E&E on the left side, and this unfortunately is BRAF negative.
Yeah,
Okay.
sorry, I missed that. So basically, yeah, of course, it makes the situation more difficult for diagnosis and treatment. But still, again, based on the fact that the epicenter of the tumor, the whole morphology and the clinical appearance, it is compatible, consistent with. So at Memorial, these kind of cases, we will send them for a trial, if there's a trial, for example. They will fit, yeah.
Yep,
So-
Frank? Yep.
I have a question. So going back to what Lisa said and Azita said, when I see this case about, could this be, anaplastic? And I agree with Lisa about, checking the next generation sequencing. Yes, we do ask for IHC staining for BRAF, but, if that is negative, we would also get, a panel to look for NTRK and RET, because those are targeted therapies that are commercially available and do show up in these anaplastic pictures. So my question, Ray, let's say we did the sequencing, and even if we didn't find any mutations, it was driven from folliculars and RAS, and this is anaplastic, I may consider offering immunotherapy up front, because this is focal. These are aggressive tumors. They do respond because of the tumor mutational burdens being so high to immunotherapy. In fact, yesterday I saw a patient in the clinic, his CPS score was 100 for anaplastic thyroid cancer. So would that have made a difference to you if we did a neoadjuvant approach? I know you talked about you're not going to avoid taking the larynx, so maybe it really wouldn't have mattered and we should focus more on adjuvant therapy. But I just wanted to bring that up as a point of interest, I guess.
Yeah, I mean, it makes a lot of sense. I think the response rates are pretty decent here. But again, it's just one of those issues about that diagnostic dilemma, right? We just don't know what it is going into it. That's the problem. I thought that this was a high grade, either poorly differentiated or a high grade PTC, but just was not expecting anaplastic.
So we're gonna wind this case up with a couple of educational. Before we do that, Frank, let me ask you, we've talked at the panel discussion a lot about anaplastics that were BRAF mutated. Now, this is a little more special case, right? We've got a complete gross resection of an anaplastic that had lymph node metastasis, at least R1 resection at the minimum. He's BRAF negative. What's gonna be our standard treatment now for that sort of anaplastic cancer, resected BRAF wild type?
Yeah, right. So questions, remind me, were the margins positive or is it completely negative?
Got to be positive, right?
That's what I thought. Okay.
Yeah.
So then obviously radiation, does make sense. So Memorial, Nancy has data, Lee, from, their group, your group, looking at, adjuvant, chemoradiation or chemoradiation up front. They use, adriamycin. I don't like to use that. I noticed on the slide here, they talked about carbotaxol. I think that's appropriate. I'll be honest, it's something, again, thinking outside the box, because these tumors, and I know they're anaplastic, you respond so definitively to immunotherapy. I know personally what I've done is check the CPS score. The CPS score is, quite elevated. I probably would forgo the chemotherapy with the radiation and offer adjuvant immunotherapy with radiation and then continue the immunotherapy afterwards.
Okay, cool. All right, Ray, you had a couple of other points to share with us?
Yeah, just real quickly right now. Again, I think the thing about this case is really the diagnosis. I probably would have done something different also if we had known up front this is anaplastic. Like for sure, from a surgical standpoint, I would have done a total laryngectomy. I think it makes a lot of sense because the margins would be wider. I'd feel more comfortable about local regional control. But most importantly, I suspect we're going to have to do a functional laryngectomy at some point anyway. And so doing this up front would have been ideal. But again, we'd have to have that diagnosis to be able to make that decision. But this is a report of 59 cases about 8 years ago about what is the sensitivity of FNA here, and it's not great. So FNA for anaplastic, 61%. And the issues here are thought to be either from incomplete sampling, morphologic issues, problems with cell block immunostaining. Next slide. So this is a meta-analysis 2 years ago about what about core? This is looking at thyroid lymphoma, anaplastic carcinoma, but only 14 patients here with ATC, but they did show that core was much more sensitive than FNA. But even with that, almost a 20% need for diagnostic surgery. Next slide. So here for a core sensitivity, 80%, positive predictive value was 100%. Next slide. But I thought this was a helpful schema right here about kind of how to proceed with rapidly enlarging neck masses. Again, unfortunately for this case, the patient did not have these rapidly progressive symptoms. But if there's a concern for either anaplastic or for lymphoma, go straight to a core. If non-diagnostic, open biopsy. If it's diagnostic, then you move forward with the appropriate treatment. But I kind of like this. I do think it makes sense. And would a core have changed stuff in this particular situation? Possibly.
Ronnie, give me 1 minute on your thoughts on this.
Yeah, so I look at this data. In my opinion, in reality today, with the tool we have, I was talking ad nauseum about the immunostain for BRAF, but also, even from an FNA, actually you can do genotyping quite quickly. Even in 10 hours, you can check for BRAF by PCR. So I think the data is probably better today in a center where you have everything when it comes to FNA and also core biopsy. And I should add, this is an element that doesn't exist in this meta-analysis. It's a center where you have people, pathologists who are specialized in head and neck. For example, I can tell you, and then I'll finish. Many pathologists do not know that you can have sometime a squamous cell carcinoma of the thyroid, anaplastic squamous cell carcinoma of the thyroid. Many clinicians think that this doesn't exist, and so that this amount of the subspecialization will make a difference and make the numbers better, in my opinion.
Awesome, fantastic. All right, let's move on to case number 2, and let's see if we can get a little work out of Dr. Brito. Yep, who was weighing in? Lisa?
It's Lisa. I just, as a head and neck surgeon, I'm just wondering the original squamous cell cancer of the larynx. I assume since you did do radiation, you were just incorporating that laryngeal cancer because, so often it's the laryngeal cancer that is perceived as the more lethal compared to the most thyroid cancers that coexist. So this was the opposite, but I just wanted to ask about the laryngeal cancer part of it.
Yeah, so this is wide field adjuvant radiation, Taxol, and then 70 gray of RT.
Yeah.
It is an odd case where the thyroid is actually coming before the larynx cancer, right? Normally we're sitting in the ballpark. Okay, all right, let's look at number 2 here. This is an interesting case.
Yeah, so just to preface this, there were 4 surgical procedures done in this particular patient, and 2 of these were done at an outside hospital. And Ronnie was actually involved in some of the review. So just to set the stage, this is a 68-year-old patient who presented back in 2016 with an enlarging thyroid nodule. She did have some other nodules in the right lobe and the isthmus, and she had a cytology done on that larger nodule in the left lobe that came back as Hürthle cell neoplasm, undetermined significance, and molecular testing was negative. So she was taken to the OR in 2017, underwent a left hemithyroidectomy, and was found at that time to have had what was believed to be a benign oncocytic neoplasm with a macrofollicular growth pattern and some degenerative changes. She was also diagnosed at the same time with CLL, which will become important as we move forward. And these slides were sent out for external review, and there was no evidence of carcinoma identified. So if we dial the clock ahead in 2021, the patient had a follow-up PET CT for evaluation of her lymphoma and was found to have a hypermetabolic nodule in the isthmus, and an FNA showed Hürthle cell neoplasm with high cellularity. And so there was deemed to be nuclear changes with enlargement and elongation and grooves. And so again, at the outside hospital, she had a second operation that involved removal of the isthmus and central compartment lymph nodes. And this time, the diagnosis of Hürthle cell carcinoma was including both the isthmus and the surgical scar. So, Ronnie, do you want to just comment on this?
Yeah, can you put though the other the initial surgery that was done, the slides from the initial surgery, Mark?
Yeah. So
or you don't want to show it now? Okay.
yeah, maybe if we just I'll get to that in just a
Okay,
minute.
okay, I got it. So here is a surgery. Actually, this is a strip of a skin, believe it or not. And what you see here is oncocytic cell, HER2 cells, really living in the subcutaneous tissue. Next one, Mark, please. So these cells have colloid, they're clearly thyroid cells, and also they do not have, by the way, the nuclear features of papillary carcinoma. The next one. So here you have a nodule that is growing in the skeletal muscle. And the next one, please, Mark. Yeah, here actually you have an example of vascular invasion. What you see, a tumor plug hanging in the lumen of the vessel. You can see the red blood cells and lined by endothelial cells. I put the arrow. And next one. Here actually you can see it in the muscle, and again these are oncocytic cells with no nuclear feature of papillary carcinoma. So this is HER2 cell carcinoma growing in the muscle and the vessel in the neck, and there were no lymph nodes. So
Hey, Ronnie, how do these the HER2 cell cancers get from the thyroid to subcutaneous tissue do we see lymphatic invasion? Is this,
yeah.
fracture of the tumor at the time of surgery? Because a lot of these come back in the scar in the field.
Yeah. Actually, to be honest with you, nobody knows exactly the mechanism. I mean, it's probably maybe it comes from surgery, but that actually becomes an interesting point, because could it be just mechanical implantation? But the fact here that we saw it in a vessel, Mike, makes it that it is really biologically invasive. It's not implanted by the surgeon.
Yeah. Okay, go ahead.
So this was the diagnosis that was obtained at that second operation. And if we dial the clock ahead, Ronnie did get an opportunity to review the original histology from that initial surgery. And one of the things that I think is important to note here, which may or may not be mechanistic in terms of what you were asking, Mike, was that the specimen was fragmented. That was removed back in 2017. And so, Ronnie, this is your re-review of that specimen.
Yeah, so again, the most important, there are two messages here. The most important thing that the specimen is fragmented, and that then it makes the diagnosis of carcinoma in the thyroid very challenging, because a lot of our entities, for example, oncocytic or HER2 cell carcinoma, the diagnosis is based on invasion. So next slide, please. So luckily here, by incredible chance, there was one slide that contained a lesional bud that is outside the capsule. And so this is an expression of capsular invasion. So in the diagnosis, we said oncocytic carcinoma with at least capsular invasion. Obviously, the extent of invasion, which is crucial in oncocytic carcinoma, cannot be really assessed here. Next
But
one.
if this was only capsular invasion, Ronnie, this would still be relatively low risk, right?
Sure, of course.
Right.
But here, unfortunately, Mike, that's why I said at least. Unfortunately, we didn't analyze the whole capsule. That's why it is crucial that the whole capsule is analyzed. But now in North America, everybody does it, even in small community hospitals. So, but this is just something happened during surgery, and
gotcha.
And the cells here are typically oncocytic HER2 cells without the nuclear features of papillary carcinoma. So it's an oncocytic carcinoma with at least capsular invasion. That's how it started.
So this patient was then referred for follow-up care once this diagnosis was changed from benign to malignant, and the patient did undergo a completion thyroidectomy with the plan for radioiodine, and so we do have, in addition to the right lobectomy, removal of skin and scar, as well as central compartment soft tissue.
Pause for just a second. JP and Monica, Hurthal cell cancer, tell me the truth. Are you guys using radioactive iodine in the Hurthal cell cancers? Are we not? JP first, then Monica. JP?
Yeah, it has been a while since I used radioactive iodine for the Hurthal cell, probably 3 or 4 years now. We had been um, paying more attention to really the other aspects. We are considering Hurthal cell perhaps not the kind of tumors that get better with radioactive iodine. I know there is literature of 5%, 10%, but even in those literatures, you can see that the response is not that great. So yes, we don't use radioactive iodine that often for patients with Hurthal cells.
Monica, where are you guys on these Hurthal cells?
Well, we will give it. We do acknowledge and we say the sensitivity to radioiodine is poor, but we give it a shot. So
Okay.
we will give at least one dose. Yeah.
Okay, yeah, but there's certainly a trend toward at least agreeing it's probably less effective or less useful. I think
Yes.
I personally am using it almost never. I think my group is somewhere in the middle, unlikely to help, but sometimes maybe. So it feels like we're transitioning over the last 5 or 10 years on that. Okay, Mark.
So yeah, this is from that third procedure. Ronnie, I think it's more of the same here.
Yeah, basically, you see the Hurthal cell carcinoma here. It's really growing in the skeletal muscle. Now, if I didn't know anything about this patient, it would be very challenging to make a diagnosis of cancer here because of mechanical implantation. But putting everything together, the fact that the nests are small, this is Hurthal cell carcinoma in
Great.
the muscle.
Alrighty, I'm going to skip forward here. And this is Ronnie's diagnosis with the secondary diagnosis of lymphoma. So here's the history. Over the 2-year period, the patients in February after that third operation had a thyroglobulin of 4.5. She had that radioiodine treatment with uptake in the thyroid bed only. And then we have a period of time here where her thyroglobulin rose from 3.1 up to 7.0. And then in 2023 reached 9.5. The patient remained asymptomatic. And then finally in 2024, she did undergo a PET CT. And at that time, there was increased uptake. We'll see that in a second in the thyroid bed up to an SUV of 12. And a CT scan did document an increasing size of what you'll see here in just a moment. So I guess either Azita or Monica.
Monica, take first shot at this one.
Well, you can see the lesion in the left thyroid bed is very FDG avid, indicating a high-grade malignancy. And you get a flip-flop. If it's FDG avid, the chance of it being radioactive iodine as well, uptake as well, is low. Usually if it's hot on FDG, it's not going to accumulate I131.
On PET scans, does CLL look any different than a Hurthal cell cancer, Monica, or are they just?
It's usually faint. I think in CLL is usually has less uptake.
Gotcha. Not really hot, and a single lymph node, I would think in CLL would be a little unusual. Okay.
Yeah.
So these are some of those adjacent lymph nodes, and she certainly has her share here. Monica, is this consistent with what you were saying?
Well, I think what you just pointed to, I don't know if lower down, those lymph nodes are fairly faint compared to the intensity in the left thyroid bed.
Yeah, I guess there are some lymph nodes over here, but certainly there was a difference here. And so this is kind of where I got involved in this patient's care. And the question became, what do we do with this intense uptake and the rising thyroglobulin? And so the patient did undergo 2 independent fine needle aspiration biopsies and I will preface this, they were very experienced cytopathologists, and both were consistent with CLL. And so now the question becomes, what do we do under the circumstances? And I think this gets to either JP or Lisa or both here.
Yeah, let's start with JP and Lisa. So JP, the patient's got recurrent Hurthal cell cancer. I've got this rising thyroglobulin with no other source that we can find. And then I got a biopsy of CLL in the thyroid bed. but what are you thinking here?
Yeah, something doesn't make sense because you're already seeing a Horto cell neoplasia that in which thyroglobulin is increasing, so you know that is coming, and you have a PET scan that is with significant SUV that doesn't fit the CLL, so something doesn't fit clinically what we're seeing in the biopsy. So certainly is concerning, and I will say that the location of that node is also concerning.
Yeah.
That observation will be problematic.
Yeah. So Lisa, you know, any presentation that starts with the patient saw 4 surgeons, including 2 outside surgeons, is not going to end well, right? I mean, I've done enough panels with you guys. I know that works. So if I send this to you and say, Lisa, I really think based on the PET scan, this is Hürthle cell cancer. I know there's no biopsy, but I'm really worried about the location. So can you just go in there and look around for me, and you tell me what? I'm still
Lisa, you muted.
Oh, I'm so sorry.
There you go.
This is that conversation with the patient, because I'm sure this patient underwent a laryngoscopy and hopefully their laryngeal function was intact, but then you have to have the difficult conversation of offering a revision surgery that has a higher risk of inducing vocal cord paralysis just from the dissection for something that you don't know for sure if it's thyroid cancer or not. But then again, if you wait, the tumor may cause that paralysis, and that will be irreversible, and that will be a risk of tracheal invasion there too. So just based on the pattern of dissemination of this disease previously noted, I think you have to be highly suspicious that this is thyroid cancer.
Yeah.
And offer the patient a surgery that has the best chance of low morbidity and higher, higher yield.
Hey, Mark, how are you thinking through this? I mean, clinically, this looks like Hürthle cell cancer to us on the PET, but you're about to go operate in a dangerous position without biopsy proven cancer. How are you thinking about this, Mark?
Yeah, so this is really a tough discussion. And so when you present all the information that Lisa mentioned here, you've got something that doesn't look like CLL, even though that's been the diagnosis cytopathologically. You've got a rising thyroglobulin, and you've got this concern that if you wait, the thing that you're worried about surgically may actually happen due to the disease process. And so the patient was indeed understandably very anxious about all the information that was presented. And so this is one of my cardinal rules of revision surgery, that as long as a nodule or the suspected lesion is readily amenable to ultrasound guidance, I usually will not go in. But we have the confounding information here that this was a very hot area on PET. And so the patient wanted to proceed with surgery. And so this was done. I went into the left paratracheal region, skeletonized the nerve, and confirmed on frozen that there was Hürthle cell present. And that's when I stopped the operation. So, Ronnie, this is what was found.
Yeah, I mean, in view of the context, yeah, this is callable as Hürthle cell carcinoma. Yeah.
And so you just mentioned that, Mark, but tell me a little bit more. So you went in, you did the surgery. Why didn't you just resect it since you were there? You made the diagnosis and got out, or what happened right there?
Yeah, so, did skeletonize, the nerve was functioning well. This is a situation where intraoperative neuromonitoring was extremely helpful. And so I wanted to document that my suspicion was there was residual disease here. And as long as I found it, I was comfortable that I had accomplished my mission. And then so I didn't really focus in on that 3.4 millimeters. So one of the questions for Monica is, for me, was the blossoming on that upfront PET scan consistent with a 3.4 millimeter focus of disease?
It looks bigger, doesn't it?
Yeah.
Yeah, it looked bigger than that.
So, yeah, so, I think one of the questions becomes, Is there more disease present there? And so our follow-up labs here, Mike, shows a TG of 9.2 going to 7.0, and kind of gets us to this final question. Where are we and what are next steps here?
Mark, can I ask you a question? That when you were thinking about what to do, did they consider thyroglobulin washout as a possibility to detect Horto cells?
Yeah, good question. So did not, that was not done. I think the cells looked so consistent
I
with
see.
DLL that this was, they did
Well,
not.
and it was Central Neck as well. And Mayo Clinic won't run thyroglobulin washout if you tell them it's from the Central Neck when we do a
Even-
diagnostic from the outside. So
Yeah,
Really, even after REI, huh?
even after REI, I've
Well,
occasionally broken the rule and called Central Neck
Yeah.
level 4. I figure it's close enough, but yeah. So I think that was the initial thought. If it's Central Neck, you wouldn't do that, but on one like this, JP, I think that would have been if it would have probably been helpful. If it was positive, it would tell you it's not as likely to be CLL, right? So
But
in
then
that
again,
sense,
3 millimeter one. So I wonder how much
Yeah.
of that. Yes.
probably wouldn't have got it. All right, Lisa, and then Frank. Where do we go from here? So multiple recurrences in the thyroid bed, in the neck over time, soft tissue recurrences, relatively, a year or two between biopsies. No gross residual disease now. Lisa, watch or go ahead and give her external beam radiation now. I forget, Mark. How young is this person?
She's
Ballpark.
68, Mike.
68. Lisa.
Yeah, no, I think that that this is a multifocal. It's shown up in the subcutaneous tissue, in the muscle, now in a paratracheal, just soft tissue. So I do think external beam radiation is indicated. And I know my colleagues in radiation oncology really don't want to radiate gross disease. They want to radiate microscopic disease. So your best chance to be effective with it is now, before she shows new foci of macroscopic disease. And I think she's already proven herself to warrant it, and her age would not argue against radiation. I think it should be a better candidate now. And then I would also ask my colleague Frank or my medical oncology colleagues about systemic therapy as well, although I think their typical response would be, in that case, to wait until she is more progressive, because she's going to have to go on indefinite therapy once she starts.
Frank, finish this one up for me.
Yeah, I would totally agree with Lisa. So, we published the study Riftos, looking at people who are refractory to iodine to, when we would start therapy. And we really didn't figure that out. We could figure out when they became symptomatic progression, and it was about 5 or 6 years, median. So there are some people we can follow effectively without systemic therapy. We always want to try to treat things focally with either surgery or radiation. So what Lisa is saying is spot on. The other thing I would do on this person is to find or to look at next generation sequencing, because it's hurtful cell or oncocytic doubtful. There is a driver mutation. Sometimes NTRK is present. More likely the mTOR pathway will be involved. We don't really have, at this stage, a really good targeted therapy for such tumors. So I think I would treat with radiation first. I would continue to observe closely, probably scans every 3 months at least to begin with, and thyroglobulin antibody levels, and then accordingly treat if the patient becomes more symptomatic or the disease burden becomes greater pretty quickly.
Gotcha. JP, last comment.
Yeah, just one thing before I guess any decision making for treatment. This patient really crossed my threshold of MRI of the brain. So when I see soft metastasis, things like that, that's probably when they say, let's MRI the brain. It's not like we do it in every patient, but this one might be one. Raising thyroglobulin markers, that kind of something is not wrong. This is not behaving in the right way.
Agree completely. Okay, guys, we got 5 minutes left. I want to do the third case. Mark, I'll give you 1 minute to present the case because I really want Ronnie to talk about this hobnail variant that we're starting to see and stratifying it. Mark?
Yeah, so very quickly, 30-year-old male presents with a left thyroid nodule, biopsy positive for PTC, and there was lateral compartment involvement. And in the interest of time, you can see gross disease in the lateral compartment, gross central compartment nodes here. Was going to have Azita. Azita, do you want to just comment this? I circled this interface between nodal disease and the esophagus. What can you tell us up front?
Nothing. Basically, in terms of imaging, we're very poor in determining the relationship of lesions next to the esophagus and evaluating esophagus. Horrible.
Excellent. Okay. That doesn't stop us from asking her. So this is his final path, and had large nodal deposits, 5 centimeters, putting this patient in the high risk. But was of note here is this hobnail cell features in papillary thyroid carcinoma. And so, Ronnie, here's my version of a hobnail.
Yeah.
Do you want to comment on this?
Yeah. So hobnail is defined. If you can go to the next one, Mark. One more. Yeah, hobnail is defined by these cells which have a nucleus that is at the apex of the cell and bulging like a hobnail. So very briefly, basically hobnail is defined as more than 30% of the cells having hobnails. And as a group, if you take them, there are aggressive cases. But however, when you study them very well, those aggressive ones have mitosis and necrosis. So and you have hobnails in young women who are completely indolent, encapsulated tumors. So it's very important that it doesn't trigger a knee-jerk reaction. And you have to ask the pathologist whether it is a tumor that has mitosis and necrosis. And now in the new WHO classification, we will put it as high-grade differentiated thyroid carcinoma hobnail subtype, or high-grade papillary thyroid carcinoma hobnail subtype. So the hobnailing by itself is not an indicator of poor outcome, but it's the fact that it's often associated with mitosis and necrosis with this proliferative engine. So it's really important not to worry and overdiagnose, especially young women with, for example, an encapsulated hobnail. And there have been papers proving this point.
So
Perfect.
anything else to show here, Ron?
Yeah, so this is a typical, again, hobnail that, by the way, occur in other type of tumors in the ovary. Again, this, so this nuclei bulging in the apical cells, but it's really important to see. You see the number here that really the outcome depends a lot of whether it has mitosis and necrosis. And actually, if you take most of the aggressive event of papillary thyroid carcinoma, the reason they are aggressive, including the TOS cell, but that will be a big discussion, is because often they have mitosis and necrosis. So if you take this away, these variants are not that aggressive. So grading is everything, basically.
So now, yeah, go ahead, Mark.
Yeah, so Ronnie, there's a lot, and I put this article in because it's a nice systematic review, but much is often made about the cut point of a percentage of cells showing hobnail variant. Do you use that at all, or is that no longer relevant?
No, with the WHO, because we have no better data, we decided about 30% of cell, less than 30% of cell. The initial study by Dr. Lloyd from the Mayo Clinic showed that they behave like other thyroid carcinoma. But again, the issue really here is, again, I have been advocating this for decades now, the grading. This is the thing that we have missed in thyroid carcinoma. It's very important in follicular cell derived, and by the way, even in medullary thyroid carcinoma. Yeah.
Fantastic. We have 30 seconds. Azita, there was one question that came in that I thought was really interesting. Any tips on differentiated CLL from metastatic lymph nodes in papillary cancer?
Well, papillary, you have cystic, you have calcified, you have hypervascular lymph nodes. I guess if it's not that, it's every other lymph node.
Yeah, that was the same thing I was going to say. The CLLs tend to look more homogeneous. I don't really see them cystic. They tend to be bunches of them on both sides of the neck. The cystic stuff certainly rings my bell of papillary and looking funny. So most of the times we don't know unless we biopsy them. So Perfect. Okay. I can't believe you guys actually did 3 cases. Fantastic. Wonderful discussion, challenging cases, different cases than we've done previously. So we are right up at the end of the hour. Thank you for a wonderful panel discussion. And for the rest of the audience, don't forget to look for, what's that called, Mark? Wisdom, words of wisdom. We're
Words-
making it up.
Words of wisdom, Michael. Yes.
Words of wisdom to some extent. Very good. Thanks, guys.
All right. Thanks, everybody. Much appreciated. Voices of
you.
wisdom. I got that wrong.
Voices of wisdom.
Voices. There you go. So much
Sorry,
for my
Mark.
marketing. Okay. Terrific. Thanks, everyone. Have a great day.